Right. I'm Adelina Comas-Herrera, and I'm delighted to welcome you all to this webinar of the Global Observatory of Long-Term Care. I'm going to start with a brief introduction about the observatory. Then we'll present to you the interest group on social care reform in England, as this is our first ever webinar, and I'll introduce you as well the speakers for today's webinar. So very briefly and within a bit of an overview of our next webinars. So the Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care systems, and it's part of the International Long-Term Care Policy Network. And the goal is to identify key shared challenges, showcase how different countries and localities are addressing them, share research evidence, and facilitate collaboration. And it's open to everyone from policy, industry, care professionals, academics, people with lived experience. How does it work? It's basically people who work in this area have a lot to share, and what we do here is to offer a platform for doing that. And we have some publications of our own. For example, we have long-term care system profiles, including one for England. We have blogs, methods and topic guides, and the real motor of the observatory and where most of the activity happens is around webinars. We have interest groups that organize the webinars. They take a topic and they develop it through different webinars over time, and then they also share relevant publications and resources, and we're gradually also building quite a library of videos of our previous events. We have also a database that covers over 600 experts on long-term care listed by country, topics, and methods. We're also building up a database of publications on long-term care, research projects, and as I mentioned, the webinars. Just so you know what's coming next, and also to give you a bit of an idea of the wide variety of topics we're covering, our next webinar is, well, we will have one more from social care reform in England, but the next one after is on the 17th of September, and it's called Future-Proofing the Workforce, Exploring the Emerging Skills Needs in Long-Term Care. The 17th of September, that's led by a group in Australia, but also with some European input. We then have one on AI for agitation, predicting behavioral distress in dementia care from the Data Science Interest Group on the 23rd of September. We've got one on continence assessment in residential long-term care on the 1st of October, and we do have an interest group on continence in long-term care. It's a really huge, important issue. And we'll have one from the quasi-experimental methods group on China's medical and social care policy, its effect on functional dependency and care deficits in older adults through what we can consider a nationwide post-experimental study. And today is the very first webinar of the Social Care Reform in England interest group, so I'm going to briefly introduce it. Our aims are to support discussions and learning about social care reform in England, and we want to learn from the history of reform attempts in England, and we will be covering that today, the experiences of other parts of the United Kingdom and of other countries, research evidence, of course, on social care in England, and we will be planning a series of webinars bringing together people interested in social care policy and reform. And we will, of course, share relevant publications. We already have a profile page that I think Nas will be is probably sharing as I speak in the chat. And we are very happy to hear from you if you have proposals for topics and speakers. And I'm going to introduce the steering group. We've got Graham Betts from the University of Birmingham, who's a former director of adult social services, Simon Bottery from the King's Fund, who's one of today's speakers, myself, Natasha Curry from the Nuffield Trust, who again will be speaking today, Clinton Farquharson from Think Local Act Personal, another of today's speakers, and Richard Humphries from the Health Foundation, who will also speak today. And we've got Catherine Needham, who I think couldn't join us today, but she's at the University of Birmingham and has done excellent work in this area. So today we're going to talk about social care reform in England. We're going to start with an overview of the state of social care in England today. Where are we? A bit of a taking stock. We will then hear about how we got to where we are now, through a bit of a history and overview of social care reform proposals and debates in England from Richard. And then Clinton will be reflecting on what happens when reforms stall and the real life costs for people who draw on care and support. And after that, we'll have hopefully time for a few discussions, but we have a lot to cover. And our next webinar after this is going to be on the 9th of September at the same time, 1 to 2. And in this one, we're going to be hearing from a project we've recently completed with Natasha and other colleagues at Nuffield Trust and LSE, and also with collaborators from other countries. And this is looking at what we can learn from the COVID-19 experiences of the long-term care systems of Denmark, France, Japan, and the Netherlands. We'll be focusing very specifically on what lessons we can learn for the social care system in England. And with that, I stop here and I hand over the word to, I think, Simon.
You do. Thank you very much. So I'm going to do a quick double-hander with Natasha on the state of social care in England. And my first part of this presentation will really be looking at the trends in the number of people receiving long-term care, the number of people receiving adult social care in England, and asking the question, what's happened to the number of people? But then I think more specifically asking the question, why hasn't an increase in spending, and we'll see the increase in spending in a second, in the last decade, led to more people receiving adult social care, more people receiving long-term care? And I'm going to whiz through this fairly quickly so that Natasha has time to speak. But let's just have a look at those key trends. So this is spending on care, and you can see that with the introduction of austerity, real term spending on adult social care fell until 2014-15. But then every year since then, pretty much, it's increased by more than inflation. The period around COVID is a bit strange because of the way deflators work, but you can see the overall trend is that since 2014-15, there's been a consistent increase in the amount of money that local authorities are spending on adult social care in England. And now we're spending £4.6 billion more in real terms than we were in 2014-15. So a pretty significant increase. However, where that money's gone essentially is on wage costs, and this is showing you what the increase in care worker pay over broadly the same period. And what you're seeing here is a 17% real terms increase in spending on in care worker pay. So care workers are now earning significantly more in real terms than they were in 2014-15. And that's essentially because of the introduction of the national living wage, the statutory living wage in England in 2015-16. And the increase in care worker pay has pretty much matched the increase in the statutory minimum wage over that period. So we've seen a lot of more money being spent, but we've also seen that there are increased wage costs. And what happened as a result of that is that we've seen a big increase in the amount of fees being charged by care providers. This is showing you increases in residential fees that providers have been charging since 2015-16. And what you can see is that for working age adults in residential care, the provider fees have increased by 13% in real terms, and for older people they've increased by 33% in real terms over that 2015-16 to 2023-24 period. So older people's fees have increased by a much larger rate than working age adults, but working age adults started at a higher place to begin with. We may or may not get that into why that is in the chat. But the point is, both have shown pretty significant real terms increases. And if we had the chart for home care, you'd see a figure of 18% over the same period. So real terms, very significant increases in the fees that providers have been charging local authorities. And what you'll then see is that fewer people are receiving support over the same period. So this is showing you how many people are receiving long-term care and short-term care over that same period. And what you can, the key one probably to look at is the 65 plus long-term care. So that's the number of older people receiving long-term care from local authorities. And what you can see is a pretty precipitous fall from 2015-16 through to about 2021-22, and then a small recovery since then. But actually still something like 5% fewer older people receiving long-term care from local authorities, excuse me, since 2015-16. There has been an increase in the number of working age adults, again about 5%, but again from a much lower base. And then also small increases in the number of people, extra people receiving short-term care. But overall, the big picture shows you that there are about 14,000 fewer people receiving long-term care now than they were in 2015-16. And putting all that together, what we call a doom loop, essentially, we think pretty much determines what's happened in adult social care in terms of support. Where costs have been increasing because of that increase in wage costs driven by the living wage. That's led to an increase in fees that providers have been charging local authorities, and local authorities have felt that they, as far as possible, have had to try and meet those fee increases in order to keep a market in place. But in order to balance the books, what they've done is reduce the number of people that they support, to ration the amount of care that they provide to people in order to balance their books. So a sort of depressing doom loop, which pretty much, I think, it shows us why to answer our question of why we've been spending more money, but actually fewer people are getting long-term care. And I'll stop sharing and hand over to Natasha.
Brilliant. Okay, so thanks, Simon, for that helpful walkthrough of the financial context and the driver of rising costs. I'm going to reflect on what that means for the wider system and what pressures we are seeing more broadly. So as Simon says, wages have risen, so we might expect that might translate into a more positive picture for the workforce, but unfortunately that has not been the case. And part of that reason is that although wages have risen in social care, they have risen less quickly than wages in other sectors that you might think compete for similar workers. So retail and hospitality are two examples that we often point to. The graph here, the yellow line is social care. The lower lines are retail and hospitality. And you can see that over time, since 2011, the gap between those sectors and social care has narrowed. And that means that social care has lost its sort of relative competitive advantage. When you put that alongside some of the conditions that we see in social care, so high use of 0 hours contracts, sporadic access to sick pay and other benefits, these other sectors can become quite attractive, more attractive than social care. So that creates a recruitment problem in social care. We also have a retention problem, because what we're seeing as the minimum wage that Simon talked about has risen, we've not seen the differential for more experienced staff increase at the same rate. And last year, an experienced worker with 5 years experience in the sector could expect to earn only 4 pence more than a new starter. So we have a retention problem as well, which means that we have high rates of vacancies. At the moment, the latest figures were around 8%, so 131,000 vacancies at any one point. That's actually improved from an all-time high of vacancies a couple of years ago, largely driven by a boost from international recruitment, but that changes to visa rules have mean that route has been closed off. So we have quite a challenging sort of workforce situation, which means that we have restricted capacity in the sector. And what that translates to is a system under quite intense pressure. And as Simon has already mentioned, we've seen access to publicly funded care becoming narrower, local authorities increasingly restricting access to public funded care, and social care really becoming a service for the very, very poorest and those with the very highest needs. And we're also seeing a shift from sort of the more upstream preventive spend to the more downstream complex care. What that means for the workings of the system is that we're seeing high numbers of people waiting for care needs and assessment. So last year, the latest figures were around just over 400,000 people were waiting for a care assessment or a package. And some of those people have been waiting for quite a considerable length of time. We also know that we have high numbers of people with or undermet needs. It's really difficult to get a solid number on that, but Age UK have put a figure of 1.5 million older people with unmet needs, and Health Watch has put a similar sort of estimate around the number of working age adults with unmet needs. So we have a portion of the population whose needs are not being met. So we have high reliance on unpaid carers, people going without, or high numbers of people funding their own care. Now, in the system we have at the moment, there is no limit to the amount of money that you can spend on care. There is no cap on that, so that people are at risk of facing catastrophic costs. About 1 in 7 of us face care costs of over £100,000 in our lifetimes. So I think some of those dynamics are driven partly by the way that we fund our system. So social care in England is part funded by national grant and part funded by local sources of revenue, so council taxes, for example. But over time, there's been an increased reliance on locally raised revenue and more pressure on local authorities to raise money locally. In the spending review that was released last month, there was a pledge for an increase in real terms spending on social care for the next 3 years, which is positive. But if you look at the detail of that, that relies on a very steep increase in those locally raised taxes and revenue, which means that we have an inbuilt sort of source of variation, an inconsistency in the country. So depending on where you live, your local authority has a different ability to raise local taxes according to how affluent the area is. So if you're in an affluent area, your local authority might be able to raise more money to be able to spend on social care. Simon mentioned the sort of pressure on fees that local authorities are facing. So although fees have been rising in line with, well, not in line with costs, they have been rising and putting pressure on funding, they haven't risen in line with the steep rise in costs. And what we know is that a lot of local authorities pay providers fees that are not quite meeting or only just meet the cost of providing care, which means that we have a very unstable provider market. We know that every year a lot of providers leave the market, they go bankrupt, they merge, they step out of the state-funded market. It creates a lot of turmoil and instability and a lack of continuity for people who rely on them. It also means that providers need to look for other sources of survival, and many of them turn to self-funders to cross-subsidise their state-funded clients. And we know that about a lot of residential care providers can charge up to 40% more to self-funders for the same sort of package of care. So there are some inbuilt sort of variations and unfairnesses that really weave their way through the system. And I think this has been a very quick whistle-stop tour through some of these complexities. It's hugely complex. And I think all of these issues need to be fixed if we're to create a more resilient and stable system. And I'm now going to hand over to Richard, who's going to tell us why these things have not been fixed so far. Thanks, Richard.
Okay, great stuff. And I've got my slides in full screen mode. So that's good. So how did we get here? Well, what a question is that to tackle in 10 minutes? Well, we got here after 27 years of policy making. There's a whole range of white papers, green papers, policy documents, and we've counted, I think, 25 different types of policy document and review and commission. And this is the latest commission that's just begun work, chaired by Baroness Louise Casey. And this is the third commission in the last 27 years appointed by the government to look at social care. And there've been others. There've been other independent reviews, and there are some of the more well-known ones. And the good news is that I'm not going to plough through the detail of what all these reviews concluded, because it would take too long and it would be very depressing, a very depressing chronology of failure. And in any case, there's a couple of documents that do go into almost forensic detail with what happened during that timeline. The King's Fund's timeline on the history of social care funding reform, and a paper which I helped to write on the history of past commissions and what the different proposals were. So if you want the detail, they're the two, I think they're the two top sources. I think actually somebody else has written a book about it all as well, but my natural modesty prevents me from remembering the author or the title, but I'm sure someone can look it up. So, so I'm not going to plunge into detail, but what I thought it will be helpful in the limited time available is just to kind of draw out some issues and conclusions and what that tells us about the future. And I think it's worth starting with the proposition that if social care reform is the answer, what's the question? And I've sort of, you know, grouped these fundamental questions, which I think social care reform needs to provide comprehensive answers to, and they're about values, the purpose of social care, what entitlements people should have, how it's all organised and delivered and governed. There's a whole range of issues about who does the caring and the workforce. And last but not least, there's the issue about funding. How do we pay for it? Where does the money come from? How are the costs shared? And what is, I think, fairly unique about England's approach to social care reform is that it is focused almost obsessively on the last of those questions, the funding. And in particular, one particular specialist question, which is how do we protect people from catastrophic costs? The 1 in 7 that Natasha mentioned that need at least £100,000 worth of care. Now, that is a legitimate policy question, but it affects a relatively small proportion of people with care and support needs. Yet it has hugely dominated the debate. And very few of all those policy documents have really come up with a rounded, comprehensive plan to look at all of the challenges and pressures that Natasha and Simon have described. So that's point one. We've focused almost obsessively on the issue of catastrophic costs, and the Dilnot Commission in particular produced what I thought were some quite compelling proposals about limiting or capping the amount of care, the cost of care that people would be expected to pay out of their own pocket. And all these years later, we're still arguing about it. And I'll come back to why. And the politics of this is difficult. And this is my second point, really, that so my slide is not, oh, here we go. Yeah. So a particular characteristic of the English experience is that proposals, particularly for funding of social care, get floated at election time. And this has been very bad news. We've had a couple of spectacular political rows involving what was called the death tax and the dementia tax in 2010 and 2017. And there's a huge spat. The issue becomes weaponized at election time when political parties want to be adversarial, not consensus building, and it becomes toxic. And politicians get the message from that social care is a vote loser, which in 2017 for Theresa May certainly contributed to the loss of her majority. And then it gets kicked into the long grass. And then at some point later, we think, social care, I've got to do something about that. So it starts all over again and we repeat the cycle. But the irony, I think, is that for most of the last 75, 76 years, there's generally been cross-party consensus about social care. It's only when elections come along that the fighting begins. So the politics has really got in the way, and because of the way that we've approached it and the timing. The third and probably my final point really about our experience in England is that we do have some profoundly deep-seated differences in how we view entitlements to social care as opposed to healthcare. And many people, for example, argue that wealthy older people that own property should have to pay the full whack for their care. And they shouldn't rely on working age taxpayers who are often less well off than they are to do that. And there are others of us who argue that actually it should be a universal protection. And this quote in the recently published NHS 10-year plan almost gives it away, you know, because it says the NHS was never intended to be just a safety net, only for those who cannot afford to pay. Yet, the irony here, deep irony, as Natasha has explained, is that that is exactly what the social care system is. It has become, and in fact, it was always intended to be, a safety net, and it's now become a safety net for people with the lowest means and the highest needs. And compared to other countries, the degree of social protection we offer to people with care and support needs is minimal. And it's this dissonance, this huge dissonance between our values and entitlements for healthcare as opposed to social care or long-term care that I think really makes England exceptional for all the wrong reasons. And actually, successive governments and successive political parties of all colours, really, have generally supported the view that social care is means tested, it is rationed, and even, you know, the Dilnot proposals, which said let the state step in when people have spent so much, even that we've struggled to get that modest improvement in people's entitlement to state financial support. So I think there is an issue of, you know, of political and public values about this, and a failure to recognise that because of demography, medical advances, the need for social care is now as universal as it is for healthcare. So what are the lessons quickly? The first one is that we've had too many short-term initiatives, and we haven't taken a long-term view, unlike other countries that have taken a much more comprehensive view of what needs to be done, and have set about a process of building support. Second obvious point is avoid general elections to bring forward proposals, particularly if they involve funding. In England, too much of the debate has been negative. It's been about demographic burdens. It's about the threat of social care to our personal finances, even the homes that we live in. We need to focus much more on the positive benefits of good care and support. We haven't been clear about the purpose and scope of reform. As I've explained, we've focused very narrowly on one or two technical policy matters. And I think there is an urgent need now to develop public awareness of social care so that politicians will be more emboldened. One of the reasons our governments of all persuasions consistently prioritise the NHS over social care is because the public prioritise the NHS over social care, because they understand what it is and they use it commonly, frequently. Whereas social care is still very much in the backwaters of public understanding. And the final point, and then I will close, is that we have spent a disproportionate amount of time, all those 27 policy papers and reviews and so on policy generation and analysis. And we spent very little time on the how of reform, the process. We have no theory of change for securing political support for delivery and implementation, and that's something that needs to be changed. And hopefully those 6 points, if the Casey Commission take them on board, will help us to learn from history instead of merely repeating it. Thank you.
In the meantime, we can introduce Clinton. Clinton, you're welcome to start.
Thank you, Richard and Simon and Natasha. I want to talk about when reform stalls, and real life cost for people who draw on care and support. And I just want to remind people, we all want to live in a country where care means something, where every one of us, no matter our age, our background or need, can count on the right support at the right time to live a life of dignity, connection and purpose. That's the promise of care. It's how we show up for each other when life changes. When someone we love becomes ill, when a child needs more support, when age shifts what we need to stay safe and well. And care is not charity. It's not a favour or a fallback. It's infrastructure as essential as roads, railways and schools. And it's what makes everything else possible: work, parenting, community and belonging. But right now in England, that promise is being broken. It's not by accident, not by misfortune, but by political choices, by delay dressed up as prudence, by decisions that treat care as optional instead of foundational. Despite rising spending on adult social care, fewer people are getting help and support. The money is being absorbed by rising costs, as mentioned, in wages, provider fees, in keeping the system from collapsing. But it isn't reaching people in need. And this doom loop, spending more, helping fewer people, patching up holes, while more people fall through the cracks. And when reform stalls, people don't stand still. They fall into crises when earlier support never comes. They fall into poverty when unpaid care replaces paid work. They fall into isolation when the system focuses on more tick boxes than on building lives. This isn't theory. This is a lived reality. It looks like a mother providing, say, 18 hours of unpaid care every day because there's no budget for her son's support. It looks like disabled adults whose care packages hasn't been reviewed in 3 years, while their cost of living quietly erodes their independence. It also looks like, for someone who's moved to a care home 80 miles from their community, not because it's right, but because it's what's left. These are not one-offs. They're predictable outcomes of a system designed to deliver the bare minimum, not safety, not dignity, and not thriving. And we call these pressure or pressures. But for people living through them, they are penalties for needing support, for surviving, for asking to live a meaningful life. And when people speak out, what do they hear? They hear there's not enough money. Let's be honest, that's not truth. It's a tactic, a way of making injustice sound far off. Because when it matters, money is found for roads, for bailouts, for short-term wins. So the real question isn't, can we afford to fund care? It's, can we afford not to? Every delay drives crisis. Every crisis costs money. We're not saving, we're spending more and fail slower. And people are paying, not just in pounds, but in pain, in isolation, and lost futures. But here's the hope. We know what works. When people have real control through direct payments or personal budgets, they don't just receive care, they build lives of meaning. When care is co-produced, it reflects what people really need because it's built with, not for them. And when support is based on relationships, not transaction, people thrive. This isn't a fantasy. It's happening now in councils that choose differently, in international models, in local pilots led by values, not fear. The problem isn't imagination, it's implementation. The barrier isn't evidence, it's will. So what now? We change the story. We stop asking what's the least we can do and start asking what kind of country do we want to grow old in? And let's treat care as infrastructure. It is, like I said, vital for schools, as a foundation for housing, and urgent for climate resilience. And let's back the people who care, paid and unpaid, with the wages and time and respect they deserve. Let's fund care in ways that reflect our real values, not just the budgets and spreadsheets, because care isn't about them. It's about us, our families, our communities, and our future. And when we choose to care truly and collectively and courageously, we all rise. Because when reform stalls, we all pay in pounds, in pain, and in principles. And when we lead with care, not caution, we build a country worthy of the people in it. Not someday, but now. Thank you.
Thank you very much, Clinton, and for bringing us to the practice, and also to a view of what better can look like, and also for giving some examples of where things are actually already working, and maybe we can learn from and make those with a wider reality. So we have time for a few questions. Thanks to all the speakers for fantastic presentations, and also for really sticking to time, because that makes it possible for us to have a discussion. And I don't know if we have any questions coming already, and you can raise your hand and unmute. And of course, the speakers, you can also talk to each other, so you can also respond. And maybe while we wait, I'm going to have a question for Richard. So it was very interesting how you described how the elections have got in the way and have never been a good time in which to debate the next social care reforms. And I was wondering how you see the Casey Commission and the way in which it has been set up, and also the timing with next elections.
I know. Well, actually, I was at a private meeting with Louise Casey last week, and I put that question to her. I said, I'm concerned that you're due to issue your final report a year before the general election. And given what's happening in the past, that seems like playing with fire. Let's put it this way. I wasn't wholly convinced by her reply. And I'm rather hoping that she will report sooner than 2028, because I think that is a real risk. And I think trying to get political census in the heat and fire of an election campaign, especially the next one, I think is asking for too much. And for people from other countries, I mean, we do have this system of electing a government which is based on a first past the post voting system. We don't have a tradition in England of constructing coalitions and alliances. It's very much winner takes all, and that kind of attitude permeates our general election campaigns. So I'll keep my fingers crossed that she can come up with something well before the next election.
I don't know, Natasha, if you wanted to come back to the same question, or
yeah, I did, if that's okay. We've done quite a lot of work looking at other countries and how they've managed to get past this issue and the political issue. Some countries do have more tradition of coalition governments, which I think helps. But I think that what we've observed elsewhere is that the pressure came from the public, the kind of groundswell of public discontent. This is not an acceptable situation. And so I think we have a real hurdle here of getting the public, with its low awareness and kind of eclipsed by the NHS and this assumption that social care is free as part of the NHS. We need to raise that public awareness, and I think that's how we build the pressure, so that as a politician standing in the next election, it's a vote winner to have a policy on social care and how you're going to fix it, not an issue that you can duck. And I think looking at kind of the narrative around childcare and where that's come from, where it's it was a private issue, and now it's an election issue, and there's a kind of consensus publicly that funding childcare benefits us all and enables our economy and society, where we need to get social care into that same space. This is, as Clinton was saying, this is a piece of national infrastructure. It's about all of us, and we need to invest in it. That's where we need to get to the debate too, but we need to get the public awareness increased.
Yeah.
Thank you, Natasha. And now I'm going to invite Vanessa David to come in with her question.
Hi. Yeah, I'm just thinking back to Clinton's thoughts and how we get people to be engaged, to create pressure. And I was wondering, I've seen in Barcelona, what they did was they created spaces within civic centres for people to come together, people who are caring, people who receive care, and have engage in facilitated sessions where they were able to sort of design the system that they wanted, as it were. And they did that very much at the kind of neighborhood level. And I was wondering if that is something that could, obviously it takes doing it, but something that could work with the idea behind neighborhood health and social care. And obviously it was something that also brought in local politicians as well as all the kind of local third sector organizations, etc. It's not really a question.
Do you like to come back, Clinton?
Personally, I agree. It's about how we create the decision making as local to people and communities. And if we're going to use the model of neighbourhood teams, I would like to see how we spell out what oversight, transparency, and accountability looks like around sharing power.
Yeah.
Simon, I see your hand is up.
Yeah, it's just on the thing about public awareness. I mean, it's really interesting when you look at the polling on social care, because if you ask people unprompted what are their priorities in politics, what policies do they want to see, social care doesn't score very well at all. I mean, usually somewhere in the region of about, well, somewhere between sort of 5 and 12, 15% at the most. So it's not top of mind for most people. If you do prompt people and you say, you know, what are your priorities, you know, and you give them a list that includes social care, then actually it comes quite a lot higher. And people do recognise that there's a problem. And similarly, the work that we do every year with Nuffield, the British Social Attitudes Survey, shows that people are really unhappy about the state of social care, even if actually they don't really know what they're unhappy about, because they're not really clear what social care is to begin with. So it seems to me that there is a latent unhappiness that people have got with social care, but it's not at the point that it's going to push any of the political parties at the moment to make it an absolute must. So the challenge is to just move it in that direction. And I think there's probably 3 areas that you've probably got to do all 3 of, really. I think you have to promote the benefits of a better system to people. And that does seem to be a message in terms of countries that have achieved reform. they've been able to say, if we do this, then this will happen and you will see a real benefit. You've got to then take advantage of that public unhappiness, the recognition that it's not working, my mum can't get support, my son with disabilities can't get support. And then I think the third thing, in all honesty, is there's a bit of luck about having the right politician at the right time that gets it and is willing to do something about it. And ironically, had Boris Johnson stayed in power for another 12 months, we would have introduced a version of the Dilnot reforms. It was he was absolutely convinced that it needed to happen. He was going to make it happen, and it would have happened, I think, genuinely. So I think it's that combination that we need to get those things lined up, and then you've got a reasonable chance of getting some sort of reform.
Thanks. I see in the chat, so there are some comments. I see a question from Birgit from Austria. Birgit, would you like to unmute and ask? Or if not, I can read it.
Yeah, so thank you. I was just wondering, so when we have long waiting lists in England right now, and what is the demographic situation? So what do you expect for the futures? Will the waiting lists be even longer, or is there not such a demographic pressure as in other countries in Europe and England, so that this is not an issue for England? So what do you expect?
Not sure who wants to answer this
Shall
one.
I start? Simon might want to come in with more numbers from 360, but yeah, I mean,
I've also noticed, one second, Natasha, I've also noticed Raphael Wittenberg is in the call. So Raphael, if you want to come in after Natasha, please do.
or before
Go ahead,
me.
Natasha.
Big in short, I think demography is we have an aging population like other industrialized nations, and so the pressure from that portion of society is going to create more need. We've also in recent years seen a sharper increase in the need amongst working age adults, so people with disabilities living longer. So there's kind of a two-pronged sort of source of need, and people living with more complexity for longer. So I think there's a number of things going on that will put more pressure on the need, that we're not keeping up with it now. I think it's going to get worse. Don't know if others want to come in on that.
Well, in Austria, we observed two developments. One is sort of the baby boomers, the very, very where many people live in a cohort. Well, some of them already changed to retirement, so they are not longer available on the market. So, for example, for providing care. And on the other side of the coin is that we have a lot of increase in demand in social care, and so this is sort of really a pressure. And even in Austria, I feel that politicians look at the situation and don't feel the pressure to act now to be prepared for the future. You know what I mean? And I was wondering how this is dealt with in England, and how we can make policymakers being aware that we run into basically in a human disaster if we don't act now.
And I see both Richard and Raphael have their hands up. I don't know which of the two wants to go first.
I'll be a gent. Raphael, you go first.
Yeah, sure. Thank you. I agree with Natasha's comments from a moment ago. We produce projections of future demand for long-term care services. As you know, we've found there likely to be very considerable increases in the numbers of working age adults with learning disabilities, but also with improved survival, also older people with learning disabilities as well. The people, as I think you say, this sort of greater survival is part of it. Survival with disabilities is part of the picture here. There may also be greater demand on formal services depending on the future of unpaid care, which is something we've also been studying. Of course, it's difficult to know what will happen. We found in the study of attitudes of sort of middle-aged people to caring for their parents that a sort of high expectation of caring for parents with relatively low levels of need, less so when personal care is required. So I think but in terms of then there's the epidemiological evidence relating to old age, and as I understand from some experts in that field, for example, at Newcastle, there are different views as to whether there'll be a compression or expansion of disability in old age. So I think that the jury on that is probably still out. But nevertheless, I would expect from the work we're doing, the numbers of older people with care needs and the numbers of younger adults with care needs are both very likely to rise over the next 10 to 20 years.
Thanks, Raphael. And Richard?
Yeah, so I recommend Chris Whitty, the Chief Medical Officer's annual report. I think it was 2 years ago now on healthy aging. And I think he took this very balanced view, and he pointed out that it is very possible for our health and social care systems to enable increasing numbers of older people to live longer and healthier lives. There's lots of things that we can do to make that possible. But even so, because the population as a whole is getting bigger, there are still going to be more people with a higher complexity and acuity of need. And I think we've been a little bit asleep on the wheel in our health and social care services, where everybody you talk to in hospitals, in care homes, in home care services is saying that, people have got, they need more care because they're living to advanced ages with it's multimorbidity, essentially, dementia and frailty and, long-term conditions and so on. And we haven't really got our services sorted out and working together properly to kind of respond to that. So this is not just about money, it's really about configuring our services correctly, both in terms of prevention and responding to acute and complex needs.
Thank you. And I also noticed a question from Andrew Rees. I don't know, Andrew, if you want to unmute and pose the question yourself. But I think you have a couple of comments and questions as well.
Have I unmuted? I think I have. Yeah, hi. So I'm slightly worried that we're all going to just sit on our hands and wait for the cases review, which we clearly can't afford to do. So what ought we to be doing now to make sure we can do the best with our existing resources? Richard, you seem to be hinting at it in terms of how we're organised.
Clinton, you go first.
Okay. From the question that you posed, Andrew, for me, this is where co-production comes in, because it's about sharing power and sharing solutions from not just from a system perspective, but from people's lived and living experience of care and support. So it's co-produced for me, and also how we use participatory budgeting, to look at how we use that to shift that decision making.
Thank you. And Richard?
Yeah, sure. So, I mean, I've been arguing for some time, Andrew, that we need to kind of dispel this myth that there's going to be some cavalry coming over the hill from Whitehall or Westminster anytime soon, because it's not. And we are where we are. We've got what we've got. And I think one of the things we've got to do is develop some bottom-up conversations within our local communities. I think councils should lead this, actually. And I've rather clumsily tried to put in the chat that I was in Camden last week, who I think are doing some splendid work on just that. They're not waiting for another national report. They're getting on, they're setting up neighbourhood forums, they're engaging with local people about, what good support and care would look like for them. And that's, if we could get that done in loads of places and try and feed that up into a big sort of national conversation, I think that would be a good thing, instead of just sitting around wringing our hands and saying how terrible it all is.
Thank you. Any last comments from the panelists? I also saw David Brindle has been active on the chat. I don't know, David, if you want to take the opportunity to have say something as well, you're very welcome. And Liz Sargent says co-production that also makes communities aware of the need to join in these conversations with the start understanding the systems. Thank you. Hi, David.
Hi, Adelina. Thank you very much. No, I was just wondering about tactics really, and what we can do to maybe put pressure on Louise Casey to bring forward that final report, as Richard suggests, and maybe also picking up Simon's point, do more to help Ed Davey, the leader of the Lib Dems, who obviously gets this agenda and for all kinds of reasons, and is probably our best advocate at the moment.
Thank you. So we've got 2 minutes left. I think you've given us today, with the comments and the presentations, a lot of food for thought on where we need to go, how we need to move from here, some of strategies that we could be adopting, and both to influence the Casey reform, but Casey Commission, but also how to make things happen in the meantime. And I do think that sets the agenda for us maybe to look, I think maybe in one of the future webinars, at some of these examples of local action to improve things maybe, and I'll be very happy to hear from suggestions from any of you on what we could cover in future webinars. You can put it in the chat. You can also contact us through GOLTC and contact any of the speakers, because we're all members of the steering group. So whoever you know, please let us have any suggestions on what to cover. As I said, on the 9th of September, we'll be looking abroad for some inspiration from Denmark, France, Japan, and the Netherlands. And we are then going to have more webinars in the future. And I want to thank you all for a wonderful start of this interest group. Hopefully we will have a role as well in keeping social care reform in life as a discussion, even if at the moment it's only about, I think we were 47 of us at one point, but hopefully we'll be reaching more and more over time. So thank you, and enjoy the rest of your day.
Thank you.
Yeah.